Welcome back again. I think we've waited enough to give time for people to settle in. We want to just introduce this series for the benefit of postgraduates and young career psychiatrists who actually want to imply all this sort of knowledge into the practice when they actually begin seeing patients. Um, Today, we thought that we should have a new module. We've done the psychopharmacology module across the other divisions. But here for postgraduates, we had done psychodiagnostics. And today we're going to begin the psychopharmacology module. It's going to be different compared to all other parameters of teaching. It's not going to be the typical classroom teaching here. We have an interesting faculty today who's going to be the first speaker and also take you across to the end of the series. He's planned actually 9 topics on various aspects of psychopharmacology and use in clinical practice too. We have Dr. Mohan Sunil Kumar today, who is the director at Augmenta Healthcare, and he is a postgraduate in psychiatry from NIMHANS. He's an entrepreneur. He actually began his company immediately after leaving NIMHANS. He works in Bangalore, and he has special interest for teaching. What makes him different is he has actually inspired young mind undergraduates in specific to take up psychiatrist career. He's been a trainer at multiple undergraduate training programs to make it to postgraduate exams. So his interest has always been teaching, and his passion has been psychopharmacology and implications in clinical practice. So he's going to have a different approach. It's not going to be the same as Stephen Stahl. He's going to make it more interactive with case-based approach. That's how he's divided all the topics that's been displayed in the schedule of. Dr. Mohan also has chosen a time when most of you are free, away from your clinical responsibilities and away from your college and reading. 7:30 is a slot that he thought would be best ideal, and based on the feedback and the comfort of the hosting team, we are going to keep it in this way is what we thought. Dr. Mohan is also a pioneer in setting up a suicide helpline for people who want to be volunteers. Most of the work that he's also done is in gatekeeper training. He's also assisted us in setting up a suicide helpline, which is the first of its kind, which is artificial intelligence enabled chatbot with a lot of other resource material and extension into responder by way of volunteers trying to answer the crisis. I will not take much time. Dr. Mohan is a good friend of mine and has always been there for any sort of academic, clinical work or any sort of troubleshooting. Over to Dr. Mohan Sunil.
Thank you, Mahesh, and thanks for the invitation and giving me a chance to kind of learn, because I'm looking forward for the next 9 weeks of learning, because it's giving me a great opportunity to learn a lot of things which are new for me, myself, and I definitely cannot compare myself with Stephen Stahl, because I guess a lot of our learnings of pharmacology, a lot of our learning also will be based through that, but of course we'll also touch in our own indigenous learning experiences and share that through the journey. Now, before wasting time, let's get into the business, because it's a lot of things can be discussed over a period of time. What we have planned in this essence of psychopharmacology, a case-based approach, is we kind of are looking at a series where we are kind of planning events to go step by step in each series, where we are looking at different conditions and dealing with these conditions in a specific way. The topics will be covered in a very simple, concise, and a clinical manner, so that any attendee is going to kind of learn something or the other through the whole process. Second is, if you are already an experienced clinician, I'm sure you'll relate to a lot of the discussions we are going to make, and I'm sure you can share your experiences through the chat with us back. Now, we'll try to kind of keep it going. What can also happen is some of these videos will be edited and put up on the link and kept so that at a later date, if you want to reference through, you can have these resources accessible at your fingertips at any point of time. Today, we are going to basically talk on language of the brain, a cocktail of chemicals and circuits. Now, what is the language of the brain? How does brain communicate, and what kind of things happen? Now, this itself can be discussed over 9 weeks, but I'm going to kind of keep it very simple for the next 1.5 hours or so. We'll try to kind of talk about some crucial aspects, which will give a basic underlining foundation on which we will build over the next 8 weeks, where we will be talking about specific conditions and the medications and management of some of these conditions and the challenges we go through as a clinician when we are sitting next to the client and talking to them. Now, you might be seeing a blank slide, but if you carefully look at this blank slide, in the left side corner, you can see a small person standing. That's how psychopharmacology or brain is. I mean, I don't think we can ever master what brain is trying to communicate, and we would never be able to kind of know everything about the brain, because we are dealing with an enormous task, especially because the number of neurons and the number of synapses we are talking is unsurmountable. No calculators can count the numbers, by the way. So I think the best part of being a good clinician or learning psychopharmacology is our ability to kind of connect to this whole enormous world of knowledge and learn and be humble enough to kind of learn every single day. Every client we meet, every patient we meet teaches us something which we never knew. Every page we read kind of teaches us. So I'm going to kind of share some of the things which I've been learning in the recent past in terms of brain communication and those, and how I try to kind of process the information when I'm dealing with the clients in my practice. If you look at the brain, basically we can look at brain communication in three important methods. One, of course, is the anatomical communication. Another communication is the chemical. The third one is the electrical communication. So anatomical communication basically is, we are talking about maybe the neurons or the brain areas which are touching to each other, or there are fibers which are going from one area to another. So anatomically connected structures we are talking about. Communication in brain can happen because of chemicals. So very common example when we talk to the patients, he says, see, you have depression, you have anxiety, you have OCD. Basically, there is some chemical imbalance in your brain. So these people who come to meet us, right, trust us and believe us and go back home and start taking the medications because we have told them that there is an imbalance. In fact, this is very unlike other areas of medicine, right? In other areas of medicine, you need to do a test, you need to show it is positive, it is negative, you need to do blood levels, show them all these things. In psychiatry, for some reason, when people come to us, they trust us. When we say there is chemical changes, they say, okay, yes, of course, there are a bunch of people who ask us questions and those, but we need to understand a lot of people trust us. And that is an humbling fact for us to kind of learn about this enormous complex organ, brain. Now, what do you mean by the electrical communications we are talking about? We know EEG is there, right? Now, EEG is something similar to our ECGs. What is important for us to kind of understand here is the electrical communications can go haywire. One of the best examples we can always give is epilepsy. Epilepsy is almost like high voltage changes and those things, right? So basically electrical current fluctuations, which leads to epileptic attack or a fit, which is a neurological condition, but sometimes they end up meeting a psychiatrist too. Why I'm stressing this point is because when we try to explain about what is happening to the client, we need to kind of see what is the way they understand. Can they understand brain as an organ and some anatomical changes? Or they can understand the chemistry of the brain and changes, or they understand brain as having some electrodes and kind of some current passing through it. Based on the client's understanding, our psychoeducation process also becomes easy. Now, you might be wondering, why are we talking this in psychopharmacology? I think the basis of this whole program is not to talk about some guidelines and not to talk about some charts and say complex and risk. Now, we are going to talk about clinical things which will be very useful for all of us in day-to-day things. We need to be able to apply these aspects. So how do we apply these aspects? How do we kind of help these individuals is what we are looking at. So sometimes using anatomical explanations, sometimes chemical explanations, sometimes electrical explanations can help the clients to understand what might be going through in their head and trust us better. And also it gives us a chance for us to help them in a much sensible way. Now, I'm sure all of us would have had this kind of a question coming up in a 10th or 12th standard, right? A 5 marks question typically asking you, draw a nerve cell and name the parts of it. I'm sure this is a question which all of us would have answered in a 10th or 12th standard. Now, most of us would have drawn some picture like this, and I'm sure many of you would be better artists than me and would have drawn it much better than me. Now, the point, what I would like to make here is we all now know with being in the medical field and learning about psychiatry for significantly, we know that is the most simplistic picture and that is extremely far from the reality of the world. No way the nerve cells are kind of so simple. They're extreme. The neurons are extremely complex structures. They kind of vary in their shapes and sizes. More importantly, the connections are even more complex. It's not just a simple synapse of two neurons touching each other. It can be extremely complex. And very commonly, at least in the initial years, we were all taught about nerve cells not being able to replicate or nerve cells not being able to regrow themselves in those, which we know is not necessarily completely true. They have their own neuroplasticity ability. And a lot of our therapies today, a lot of our medications today is trying to work on this neuroplasticity of the brain. The ability to flex and bend the muscles of the brain is something which we are looking at. So that's something which we know. Neuroplasticity is the key. For example, electroconvulsive therapy, the basis of electroconvulsive therapy is neuroplasticity. So increasing BDNF factor leading to neuroplasticity is some of the very well-known explanations for the effect of ECT. So what am I trying to tell you here? Whatever we have learned, I guess it's important for us to kind of catch up those points and kind of understand here. Before we go further, in this lecture, we will have a lot of polls here and there happening. I might put up a question and ask you some answers. So we'll give about 15-20 seconds for you to answer the poll. In your own phone, you might get a screen where you have to answer the poll. Go ahead and answer the poll for the first question, which is coming up for the day. The questions are very simple. There's no right and wrong. I'm just trying to kind of keep it interactive. You can mark whatever you think is the right here. The question which is coming up is this: synapses are between which of these structures? The axon and the dendrite, or axon and the soma? Soma is the body of the neuron, right? Axon and an axon, or is it any of the above? So, Sriram, can we have the poll up so that we can kind of allow the participants to answer? Please go ahead and answer. Okay, so it's nice to see a lot of people answering. Majority of them, about 76% of them, have chosen choice 4. Now, I'm sure we are dealing with a very enlightened crowd. In fact, I might end up learning from you people than I sharing my knowledge, but it is very important for us to have clarity on basics, because a lot of times the basics is what makes a lot of difference. So with this understanding, let's see whether it is kind of true or false. So what we need to understand here is when we are talking about synapses, typically the explanation which is given to us or told us is an axon comes and ends at a dendrite. An axon and a dendrite is the typical synapse. A pre-synapse neuron and a post-synapse neuron, they come and join. That's what is explained to us. But we also need to understand there can be other kinds of connections. The axon not necessarily can end on the dendrite, but it can also end on the body or the soma. Axon can also go ahead and end on the axon itself. So one of the neurons axon can come and end at different parts of the axon. Why is this important? I'll kind of help you to understand. Some of us here might be specialists in Veena or guitar, right? If you see Veena and guitar, what happens typically? These are just about few strings there in that instrument, and with hand movements at different places, they're able to produce different sounds and different musical tones, right? So if you see, with just few strings, with hand movements proximally and distally, they're able to bring in different music. Can you see what beautifully happens there? The different kind of musics they can bring in. That is exactly what this slide is trying to tell you. The axons not necessarily only go and sit on the dendrites. It can sit on the body. It can sit on the other parts of the axon, the proximal part of the axon, distal part of the axon, middle parts of the axon. By thereby, it almost brings in a modulation system in the brain. So the neurons can be modulated. So if you sometimes wonder why the same drug does different things at different places, maybe it can modulate the neurons at different places in different ways. And it's a good to know that brain is almost like these instruments being played, and the finger movements is what is these dendritic communications and the axonal communications are making. So it's a good way to remember the analogy and take it further. So next question is, it's a smaller question with only two choices for you. Neurons are activated by neurotransmitters only. How many of neurons are activated by neurotransmitters only? Can you put up the poll, true or false? Shriram, can you put up the poll for us to answer? What do you think is the answer? I do expect majority of them telling it to be false. But what is interesting to see is we have about 17, 18% of people actually telling it could be true. Maybe it's the fake end of the day, they're very tired. That's why they might have slipped and answered the wrong thing. But I'm sure all of us know neurons need not be just activated by um, neurotransmitters. There are many other methods and strategies by which neurons can get activated. Why am I stressing this point is because uh, we need to understand when we're talking about brain, it's just not about neurotransmitters. A lot of other things can play a role. Neurotransmitters are one of the important neuronal activation system. But again, you can have electrical signals activating neurons. You can have drugs which can go and activate neurons. You can have trophic factors, the neurotrophic factors which can activate neurons. We can have hormones which can activate neurons. We can have the toxins which can activate neurons, we can have the light which can activate neurons. For example, for melatonin secretion to happen in the night and sleep to come better, we all know bright light in the morning would matter a lot. So one of the important things to explain in people who have chronic insomnia and those is to, the moment they get up in the morning, we want them to open up the screens and we want them to get into fresh bright light so that the brain gets enough signals and says, okay, this is daytime, this is nighttime, and brain learns, okay, what is the diurnal variation and those. So I guess neuronal activation can happen not just by neurotransmitters, but a lot of other things can cause neuronal activation. Hormones do play a role significantly. We all know how premenstrual syndrome and postpartum periods can be influenced because when women go through these premenstrual symptoms and all, we know a lot of hormonal factors play a role in the mood changes which happen. Drugs definitely can play a role. We know how substances can induce psychiatric illnesses sometimes, or worsen psychiatric illnesses sometimes, or sometimes even ameliorate some of the symptoms and reduce some of the symptoms. So I guess it's important for us to kind of understand neuronal activation can happen because of various reasons. And one of the important ones we are talking about is the neurotransmitters. So when you are talking about neurotransmitters, there are a hell of a lot of neurotransmitters, but some of the important neurotransmitters are in the yellow, which is serotonin, norepinephrine, dopamine, acetylcholine, GABA, glutamate, and those. Glycine, histamine, hormones, and neurotrophics are some of the other important neurotransmitters. Not that they are less important, they are also important, but a lot of psychiatric conditions we try to explain from those in the yellow side. Now, what is important for us to know is along with these neurotransmitters, we also have our own inner club drugs. We have substances which people use for addiction, like cannabis or opioids, right? We have our own inner club drugs, which I call as. Why is it important for us to know? Is because a lot of youngsters today would have read on the internet or kind of are well versed with some of the things which happen in the brain, and they come and say it's okay to take weed I hope, doctor, as a psychiatrist, you know there are receptors for weed in the brain already. There are some endocannabinoids. I hope you know that. So you need to understand, when we're dealing with such knowledgeable younger population who are kind of well versed, we need to use different strategies to talk to them. So it's important for us to understand. Sometimes our clients might end up teaching a lot of neuroscience to us than actually what we might know, because today knowledge is very much available at a click. So two important inner club drug systems we have is the endorphins and the endocannabinoids. I will be talking about endorphins and endocannabinoids separately when we are talking about substance and drug related issues. At that time, we'll be talking extensively on endorphins and endocannabinoids. Here, I'll just mention it and leave it here. Okay, so let me go to the next important point here. Which of the following neurotransmission directions can happen? Now, if you're talking about A, B, and C being neurons, how do you think neurotransmission will happen? The choice given to you is A to B, B to A only will happen. Nothing will happen with C. There will be no communication with C. A will come. The neuron A will communicate to B. B can communicate to A, but nothing to do with C is one of the choices. The other choice you have is A can communicate to B, B can communicate back to A, and A can also communicate to C. So what do you think is the answer? Now, please put up the poll, Shriram. Is it first one, that is A and B only, and C is not going to be involved in neurotransmission, or C can also be involved in neurotransmission? What do you think is the answer? It's nice to see a lot of people answering so quickly. It makes us feel pretty good that you are very interactive and those things. Go ahead. Nice. So I guess majority of you almost feel that A, B, C can have its own communication strategies, right? Now, why have I put up this question is because we are moving ahead to slowly understand how brain communicates further and further. We are kind of, I did tell you how neurons get activated. I did tell you about how different connections can happen, the axon, dendrite, and those things. So now we're talking about transmission, right? So when you're talking about transmission, it's good to know, normally, all of us in our medical school would 100% read about the neuron A communicating with neuron B. That we all know. Our question is, can B communicate back to A? And our question is whether A can go ahead and communicate even with C, which is not just next to the synapse. So let's take, there are two neurons, one the top and the bottom, right? The black and the gray one. If you take that, if from the black to the gray, if it goes, that is called as routine neurotransmission from a presynaptic neuron to a postsynaptic neuron. We all know that. But there is a concept called retrograde transmission. In retrograde transmission, what happens is the postsynaptic neuron will send signals to the presynaptic neuron. The postsynaptic neuron will send signals to the presynaptic neuron. There are three important places where it specifically happens, and it is good to know clinically. There are three important places. One is the place where endocannabinoids work. Endocannabinoids are typically working on retrograde transmission. Second is nitric oxide. And third is the nerve growth factor, the neurotrophin nerve growth factor. So these are three important situations where retrograde transmission happens. It's a good point for us to remember because it's a little unusual from the routine where we know transmission goes from the pre to the post. Here it is post to the pre, which is called as retrograde transmission. So out of the blue, I want to ask you a point. Can anybody tell me which of these substances is called as penis gas? Penis gas. I hope you have an answer. If any one of you have an answer, maybe you can put it up in the chat. What is penis gas here? The answer is penis gas is nitric oxide. We would have read about nitric oxide being important in vasodilation and erection, right? So that is why it's called as penis gas, one of the names which is given to this nitric oxide, which is considered as a neurotransmitter now. Now, one of the important transmissions is the retrograde transmission, which I highlighted. Another important transmission which we should know is called as volume transmission. This volume transmission has another name called as non-synaptic diffusion. Non-synaptic diffusion. It's a or non-synaptic transmission. Now, what is this non-synaptic neurotransmission or non-synaptic diffusion? You need to understand what happens here is little different. Typically speaking, a pre-synaptic neuron and a post-synaptic neuron communicate to each other. That is through the synapse, right? What is non-synaptic or a volume transmission? Here, the neurotransmitters which are released don't only work on the synapse which is next to it, but diffuse around. It is a volume diffusion which diffuses around and stimulates and works on the other neurons which are there around and other areas of the brain. That is what is called as volume transmission. So the more the volume or puff which is released, it goes and acts in different areas. So that is also one of the reasons why you need to understand, even though you desire to give a medication for a particular effect, it can so happen that you don't get only one effect what you want. You might end up getting a lot of other side effects or undesirable effects. Or sometimes we have seen that when you hike up the dosage small amounts, patients feel much better. Maybe the volume transmission, other things happen. So it's important for us to understand the communication systems in the brain are pretty complex, and it is not as simple as give the medication, patient will get better. Sometimes we need to increase the dosage, decrease the dosage, ask ourselves, why is this patient responding? Why is this patient not responding? Why is this patient responding but having side effects? Why is this patient not responding and having side effects? We'll touch upon these things later in a few other lectures in the coming weeks. But one point I would like to highlight is, let me give an example of dopamine for that matter. If you look at dopamine, see, I've drawn a picture of brain. It looks very crude for you. The bottom side is the occipital lobe. The front area is the frontal lobe. Now, if you see, I put blue spots, much bigger one in the frontal areas. Whereas somewhere in the middle, I put a small few dots of blue points, right? What am I trying to tell you here? If you look at dopamine, reuptake happens much more efficiently in the basal ganglia area, whereas dopamine reuptake is not that efficient in the frontal areas of the brain. So imagine I'm giving a drug A and I'm trying to increase the levels of dopamine. If I'm trying to increase the levels of dopamine, the dopamine level will increase much higher in the frontal areas of the brain because the reuptake pumps are not very efficiently working. Whereas in the basal ganglia, reuptake pumps are working much better. So it might not increase that much. So why am I telling this is because you need to understand a lot of this explanation can be done by volume transmission, volume neurotransmission as an example. So it is good to know retrograde neurotransmission, volume neurotransmission are examples for us to remember, which will help us to kind of highlight how neurotransmission happens. Now, next point for us to learn is, there is something called as excitation secretion coupling. What is this excitation secretion coupling? Now, when the neuron gets excited, right, it ultimately comes to the terminal, the synaptic terminal, and it many times secretes chemicals, the neurotransmitters. This is what is called as excitation secretion coupling. Now, if you see, most of the times the excitation component is the electrical component and the secretion component is the chemical component. So this process of excitation secretion coupling is an electrical and a chemical connection process which happens. So electrical activity gets converted into a chemical activity. Why am I stressing this point is because this point or this juncture is a place where a lot of our voltage gated channels work. Now it's common sense, right? Why would a voltage gated channel work here? Because these channels will be sitting there, and when there are voltage changes which happens and comes near to it, and suddenly the channels will realize, oh my god, the voltage is changing, so I have to fire now. They open or they close depending on what the channel is supposed to do. It works. And how does it get the message? By the voltage change. So voltage gated channels is one of the crucial factors which plays a role in excitation secretion coupling. That's a point for us to remember. The two important types of voltage gated channels we look at is the sodium channels and the calcium channels. The sodium channels and the calcium channels are the two important voltage gated channels which we look at. Now, this synapse is just not a simple one end or a boundary, right? It's a complex thing. It's a much more complex thing. So to make it very simple, what I've done here is, if you're looking at this being the synapse, there are two important proteins you should remember. One is called as the snare proteins. The snare proteins are proteins which plays a role significantly in exocytosis. These are, to give you an example, it's something like this. Let's imagine I'm extending my hand like this, right? There is an electric current which is coming from there to this voltage. Let's imagine my head is the voltage gated channel. The electric current comes like this. The voltage gated channel will get sensitive. Let's imagine I'm a calcium voltage gated channel, my head. So what happens is, because the voltage changes happen, this calcium channel will say, oh my God, there is voltage channel, let me open up. When they open up, calcium comes in. When calcium comes in a lot, the synaptic vesicles, the vesicles which are sitting there, will be pulled to the edge, and the proteins which will pull them to the edge will make them release the neurotransmitter, will make them release the these are called as the snare proteins. The snare proteins kind of play a role in exocytosis, pulls the vesicles and says, neurotransmitters, get lost from here. So that process is what is called as snare proteins playing a role. It is not just snare proteins, a lot of other proteins are there. SNAP25 is one of the names, synaptobrevin, syntaxin, and synaptogamin are some of the important snare proteins we have. Now, these are all playing mostly a role in exocytosis, but some of them can play a role even in endocytosis too. In endocytosis, a few other ones like clarithrine and dynamin are some proteins which are specifically known to play a role in endocytosis. So snare proteins mostly exocytosis, clarithrine and dynamin are some which play a role in in endocytosis. That's a point for us to kind of learn and remember. And nowadays, with all the beautiful technology where they can identify each of these proteins, more newer drugs are trying to look at these micro targets and try to see, can we make a difference in these snare proteins and clarithrine dependent proteins, and try to bring about further changes. So that's how psychopharmacology is evolving over a period of time. So let me go to a very practical challenge we see day to day. I am sure a lot of times we see some prescriptions, right, where there are patients on 5 drugs, 10 drugs, 7 drugs, 8 drugs, and sometimes we wonder what the hell is happening. Why are they be put on so many medications? And we get angry sometimes on the fellow psychiatrist or the doctor who has prescribed so many medicines. Now, typically, I also used to get a lot of anger whenever I used to see a prescription which looked very big and I felt this patient has been prescribed irrationally. Interestingly speaking, I remember when I had one of the conversations with one of my friends with whom I had studied Nimans. Many years later, we had met up for dinner. As we were casually talking, I was telling how I get upset about these big prescriptions and multiple drugs being put and those. That's when he told very nicely. He said, Sunil, you're willing to prescribe aripiprazole? He asked. I said, yes, I do prescribe many times in my patients. He said, see, it's a dirty drug. Tricyclic is a dirty drug. It works on multiple receptors. It does multiple things. Now, how different is that compared to a prescription which has 4 drugs or 5 drugs is what he asked. Now, that made me thinking, because kind of almost similar to some extent, right? Yeah, a single drug works on, for example, there is this drug which is new for depression, right? Vortioxetine. Nobody knows what all receptors it works on. It seems to work on many receptors, doing multiple things. It does one side antagonist, one side agonist. So it's a complex drug, right? So it does multiple things. So it is almost like a single drug doing polypharmacy. Not necessarily you need 10 prescriptions or 10 drugs to be written in a prescription. So why am I highlighting this point is because don't get offended and get angry the moment you see a huge prescription. Don't stop all the drugs. First ask yourself, what are we dealing with? Why is this guy taking so many medicines? And is he responding to all these things? Or is this medicines causing side effects? Is there some interactions which are happening in these drugs? So I think it's important for us to realize each huge prescription patient, a patient who comes in with big prescriptions, we can't take them lightly and just remove all the medications. We need to ask a lot of questions before we touch their prescription and change. That's important for us to learn. So that's something which I wanted to highlight. And it is important for us to realize as a clinician, when we kind of intervene and decide, okay, here is this medication, start this medication, we actually are at a point where we are starting a path of uncertainties. We all know many a times we diagnose people with depression, we give them medication, and what happens is in a few weeks to a few months, they have a switch or they kind of get into bipolarity and those things. So we, for the first time, we find, okay, this person can get into bipolar, we change the diagnosis, we add mood stabilizers. So uh, as a psychiatrist, when we're prescribing medication, I think we need to understand there's a lot of path of uncertainty which we have to accept. Now, why am I stressing this point is because it is important for us to realize it is not just start up medicine and hope things will go fine. You need to expect things going wrong. You need to expect side effects. You need to expect undesirable effects which can happen. Now, when you look at it as your clinical practice, so what you do is sometimes you go slow when you're worried about it, go slow, tighter the dosage, also gain the confidence of the patient. And sometimes it's also important for us to say, I think this is the intention of we giving the medication, but you are always welcome to reach back if you find anything else which is different. So when you talk to them and make them understand that it's a complex thing which we are helping, and sometimes it takes time, many times patients give us the chance. So it is important for us to kind of convince them and make them understand why they need to wait for 3-4 weeks for the medications to kick in its effect. Otherwise, what is going to happen is maybe they would have responded to escitalopram, but we might remove it off within 3-4 days because patient says it's not working. So it's important for us to kind of work with the patient and explain them the science behind what we know and what we don't know. That gives the client or the patient to understand the problem which is happening, and they also are willing to give the time for you to be a better clinician. That's the key. At the end of the day, helping another person in pain is our job, right? So that's something we need to work on. So when we start off giving a medication, it's just not about taking a pill, swallowing the pill, and hoping things will get better. We are hoping some things will get better. We don't know what all things will get better, and we don't know what all things will get worse, because signal transduction process is a very complex process. When a drug is given or a neurotransmitter is released, it can change multiple things in multiple receptors and multiple circuits, and different things can change in different periods of time, right? So we all know some side effects start from the first dose. Some side effects start after a few days, few weeks. Some side effects start after a few months. So it's important for us to understand different effect and side effects can have its own timeline. It is good to ask always, okay, from when have you been taking this particular drug? When have you been seeing the side effects? For us to kind of clinically correlate whether it is because of the drug or not. I'm sure as a clinician, many times you end up seeing patients coming and telling some weird things like, okay, they would have started some medication. They'll say, doc, I'm having fever today. Is it because of the medicine? The medicine might have no link to the fever they might be having, but they might be worried because for them there is a timeline connection. I started the medicine, next day I'm having fever, so the medicine and fever could be linked. But if a good clinician's job is also to ask ourselves, by any chance, is this a symptom of neuroleptic malignant syndrome? Is this a symptom of serotonin syndrome? Because these are all problems which are life threatening and need to be identified. So it's important for us to realize when a drug is given, we kick in a process and we need to see how much time goes by and what are the effects and issues which comes up. So that's something which we need to be really looking at to address here. Basically, we can keep it very simple and remember there are four important transduction pathways or four important messaging pathways and ways communication happens. One is through the G proteins, another one is through the ion channels, third one is through the hormones, and fourth one is through the neurotrophins. So these are four important transduction pathways through which most of the neurotransmission happens. Now, if you look at the G proteins, basically it is trying to work on the cyclic AMP and the protein kinase A. So G proteins, cyclic AMP and protein kinase A are major messaging systems through which you work on G proteins. When you're talking about ion channels, you're talking about calcium ion channels, or we are talking about calcium and calmodulin dependent protein kinases. The protein kinases which are dependent on calcium ions and calmodulin are something which plays a role in ion channel communication. When you're talking about hormones, typically a lot of these hormones get into the cell, bind to their receptors. This hormone receptor complex then get into the nucleus and then bring about genetic coding changes, which brings about effects. Neurotrophins, lot of research is happening, and the middle agents of neurotrophins are kind of having funny names, crazy names, which most of us don't even understand. We keep reading and we keep forgetting. But this is where a lot of research is again happening. We'll try to touch upon some of those most important ones in when we are talking about schizophrenia, and especially we are talking about mood disorder. We'll touch upon neurotrophins in those topics. So basically, to keep it simple, there is this first messenger, second messenger, third messenger, fourth messenger. Sometimes there can be many messengers in between also, right? It's a complex process which can happen. What you should know here is when we give a medication, it is not as simple as, okay, serotonin levels will increase, depression will go away. Why does the depression go away? What is the change which happens? In fact, clinically, if you see a lot of clients, right, you would notice some things. They will tell you, doc, I have never been like this. I've started becoming like this. Now, why have they changed is the question. That's something which we need to ask ourselves. Is there anything different in their body now compared to the many years they have gone by? Many people who go through extreme emotions, especially with borderline personalities and those things, right? They very commonly, if they get better, they will tell you, earlier I used to be extremely emotional. These days I'm pretty numb to my emotions. Now, we don't know how they use the word numb. Sometimes numb could be a bad term for a clinician to hear. Sometimes it's a better term, because in borderline people, we don't want them to go through extreme emotions. We want them to kind of numb their responses and feel little neutral and zero, right? We don't want to go to plus 100 or minus 100. We want them to be in and around zero levels. So it's important for us to understand these transduction processes and the messaging systems gets kicked off when we give medications or when we do therapy. It takes its own sweet time and a lot of things change. And this change are linked with time, you need to understand. Why is this important is because if I go to gym for one day, I can't expect any changes to happen. But if I want changes to happen, I need to go to gym pretty long, consistently, right? So the same way, therapy, one session might not work, one dose of medication might not work. So it's important for us to understand a lot of effects to be maintained. We need to have medications regularly being taken, or sometimes it needs to be given for a decently long time. That is the reason why medications are given for a decently long time and then tapered and stopped, so that the relapses could be less and those. So it's good to understand what could be the connections of why are we doing this. So next time, whenever you're reading some guidelines or any other book on psychopharmacology or drugs, you can ask yourself, okay, why is this particular drug given like this? Okay, why is this drug slowly tapered rather than abruptly stopping? So that is what will give you an edge to become a much better clinician than where you are. So what is our ultimate target, by the way? Yes, it is the behavior. As a psychiatrist, I want to change the behavior. I want to change the cognitions of the person. But how does this behavioral and cognition changes happen? It happens basically by bringing about changes in the phosphoproteins and the genes. We do change the genes, we do change the phosphoproteins, and that is how we can make a lot of difference. Now, when you're talking about genes, we can bring in changes which is very early. We can bring gene changes in few hours time. From the time you give medication, from the time you start doing therapy, within a few hours, there are early genes which can change, whereas the late genes kick in much later and play a role. So there are two ultimate issues which we are trying to address. One is, are we creating adequate, important proteins, or are we kind of working on what proteins we are requiring? And are we activating or deactivating the genes in an appropriate level? By this, they're trying to bring about changes in an individual's clinical illness or his behaviors or their changes in their cognitions. We try to focus by looking at these two main targets. So we can talk about genetics and those for longer time, but I'm trying to keep it very simple here. It's a very simple concept for us to understand. If you look at the DNA strip and the genes, right, there are a lot of genes, but you need to understand the coding component is very, very small component. Majority of the genes are roaming around for regulating the coding component. Getting it? So the majority of the genes are basically regulator genes. Small amount of the genes are what actually coding these specific proteins we want, and kind of phenotypic and behavioral phenotypic and those things. Majority of the genes are basically regulating the whole system. That's an important point for us to understand. And there is a marriage between these factors, right? The transcription factors, the RNA polymerase, these are all playing around to produce genetic changes to ultimately produce what we want, a gene product, right? We want a gene product, something which is sensible, which helps the individual at some point of time. Now, if you keep it very simple, the phosphoproteins and proteins where we are looking at being produced, we are trying to produce proteins which regulate other proteins. Okay, so that is what we are trying to do. Now, we are trying to regulate the system constantly. There are two ways which we can do: kinases and phosphatases. What do they do? Kinases basically phosphorylate proteins and regulate the system, whereas phosphatases dephosphorylate the system and regulate the proteins. So basically in our body, it's very simple. The kinases keep adding phosphates and kind of activating or deactivating systems, whereas phosphatases kind of do dephosphorylation, thereby regulating the system. So that's how they do. So wherever you read, how much ever you read, ultimately your mechanisms of action will in and around be around these chemicals and in and around these enzymes. That's how it works by. But just to kind of tell you how complex it can be, I've just put up a slide here to kind of say what kind of different enzymes can play a role. Some of them have funny names, RSK, ERK, MEK, like your PPL teams, different names and those. So let's not worry about it. When we talk about some conditions, we'll take some of these things important. But before I go further, I hope some of you would have noticed GSK3 there, glycogen synthase kinase 3. Now, I guess you would have already thought where it plays a role, right? Which is a drug which is an inhibitor of glycogen synthase kinase, by the way? Any guesses? What do you think is the answer? Glycogen synthase kinase 3. Lithium plays a role, right? Lithium plays a role in GSK3. So that's important for us to know. We'll touch upon lithium when we talk about mood stabilizers in a later week session. I put up here Krebs because a lot of research happens about Krebs, and invariably when you're reading textbooks, this Krebs will come somewhere or the other. I've drawn a crab for you to remember the Krebs much better. Now, what is this Krebs, by the way? It's basically a transcription factor. I did mention transcription factor playing a role in genetics and expression, right? So it's a transcription factor. It's a cyclic AMP response element binding protein. Cyclic AMP response element binding protein. I did tell you cyclic AMP is one of the kind of second messenger system. So basically, when you read response element binding protein, basically in your head, even if you don't read psychopharmacology in detail, you get an idea that, okay, genes, there should be some phosphorylation, there should be some protein, there should be some receptors, there should be some neurotransmitters or neuronal activation which can happen. So if you have a vague idea of how things happen, you can always learn further and further from your books whenever you kind of coming across newer treatments and strategies. When you're talking about genes, I did mention about immediate early genes. So a very common question which can even come in your exams and where they can ask you to write about it is immediate early genes. There are two important immediate early genes, the CFOS and the C-Jun. The CFOS and the C-Jun are early genes which are very, very important. The CFOS and C-Jun, they join together and they become a transcription factor, which is called as a leucine zipper transcription factor. Okay, they join together and become a leucine zipper transcription factor. And this transcription factor basically further goes ahead and brings about all the genetic modulation and protein production, which is required for behavioral processes to happen. Okay, now I think a lot of things have become overdosed, and some of us would have got, okay, it's getting too much. So let me go light now again. Let me ask a very simple question. What do you think is the answer for this? Majority of the psychotropics work on what? One, ion channels directly, or is it enzymes directly? Please put up the poll, Sriram, for others to answer. Please put up the poll. Yes, thank you, Sriram. Yeah, majority of the drugs work on ion channels directly or the enzymes directly. Okay, interestingly speaking, a lot of us have already answered. About 70% of them who are participants here have answered this poll. I'll tell you the answer. You'll realize why I'm laughing around here. The point here we need to understand is psychotropic drugs, in simple, have 5 major targets. Psychotropic drugs have 5 major targets. Most of the psychotropic drugs, almost 30% of our psychopharmacology drugs we have, work on the transporters. Another 30% work on the G proteins. Okay, so most of the drugs work on the transporters, other 30% work on G proteins. Now you'll be telling, sir, you never gave this choice. Why are you asking this question? So it was just to trick you around. We wanted to see how many of you answered. The fact that 78% of us answered says that, I mean, it's good for us to learn, right? We're all learning together. So I hope next time we should be able to kind of deal with it much better. Now, 20% of it deals with the voltage gated ion channels, another 20% deal with the ion ligand gated channels. Whereas about only 10% plays a role in enzymes is what you need to understand. So a small percentage of our drugs work on enzymes directly, but majority of them work on the G proteins and the transporters. G proteins and the transporters. So let me take you through almost the physiology, which you would have read in the first year of medicine. I'll show you a picture here. Let's imagine there are 12 transmembrane proteins. Below, I put 7 transmembrane proteins. What do you think is 12 transmembrane protein? And what do you think is a 7 transmembrane protein? So I'm sure 7 transmembrane protein, most of you will know. It is the G protein, right? G protein is typically a 7 transmembrane protein, whereas 12 transmembrane protein are transporters. I just now mentioned to you that transporters are one of the important psychotropic agents, and these transporters mostly are 12 transmembrane proteins put together, whereas your G proteins are basically 7 transmembranes put together. Now, when you're talking about transporters, I've tried to keep it very simple and clear for you to understand. There are 2 important plasma membrane transporters we have. Now, see, basically, if you're talking about transporters, there are 2 levels of transporters we should know. One is the plasma membrane transporters. Another one is the vesicular transporters. Plasma membrane transporters, vesicular transporters. So plasma membrane transporters are 2. One is linked to the SLC6 and other one is linked to the SLC1. What is this SLC? Solute carrier transporter. The solute which is involved is the sodium or the chloride couple. So SLC6 and SLC1 are the 2 important types of plasma membrane transporters. Majority of the neurotransmitters which we talk about, serotonin, norepinephrine, dopamine, not just that, GABA and glycine, the inhibitory substances, right? GABA and glycine, they all are linked to SLC6. Getting it? Serotonin, norepinephrine, dopamine, 2 inhibitory substances, GABA and glycine, are all linked to SLC6. Whereas SLC1 is linked to basically the stimulatory transporter, that is the glutamate, is what you need to understand. So this is a basic understanding of plasma membrane transporters, plasma membrane transport. Now, let us talk about vesicular transporters. Now, vesicular transporters are nothing but intracellular synaptic vesicular transporters. If you're looking at intracellular synaptic vesicular transporters, there are three important here: SLC 17, SLC 18, SLC 32. SLC 17, 18, and 32 are the three important types of synaptic vesicular transporters we have. Now, in this, again, what you need to understand is SLC 17 is linked with the glutamate transporters, whereas SLC 18 is linked with the monoamine transporters or acetylcholine transporters. Even histamine is linked to the same SLC 18. Understood? Monoamine transporters is linked to SLC 18. The acetylcholine transporters are also linked to SLC 18. When you're talking about SLC 32, it is linked with the inhibitory amino acid transporters. Inhibitory amino acid transporters. Getting it? That's important for us to kind of remember and understand here. Since we are talking about inhibitory amino acid transporters, one highlighting point I can tell you, I have kept it easy for most of the PGs to remember. When you're talking about GABA transporter, four alphabets, right? GABA, GABA transporter. There are four important types of GABA transporter: GABA 1, GABA transporter 1, GABA 2 transporter 2, GABA transporter 3, and GABA transporter 4 are the four important types of GABA transporters. In that, this GABA transporter 4 is also called as beta-in transporter. Okay, it is also called as beta-in transporter. Easy to remember. GABA, four types: 1, 2, 3, 4. Simple. Like that, I think if you want to enjoy the whole psychopharmacology, I guess the point is to kind of code and teach your brain how to remember. I mean, it might not be necessary for you to be a good clinician, but it might make you learn this enormous knowledge of brain much better when you kind of remember these things very well. So that's the whole process of making this whole slides look very simple and easy for us to understand. When you're talking about glycine transporters, you need to understand glycine transporters are GLY, glycine. So glycine transporters are glycine transporter 1 and glycine transporter 2. Glycine transporter 1 is mostly in glial cells, whereas the glycine transporter 2 is mostly in the neuronal cells. Glycine transporter 2 is mostly in the neuronal cells, whereas glycine transporter 1 is mostly in the glial cells. We will be talking about some of these transporters, especially glycine and all. A lot of research in schizophrenia today revolves around glycine, glutamate, those kind of transporters. We'll try to touch upon this when you're talking about psychosis in one of the weeks, which comes up later sometime. So let me ask this important question here. What do you think is required for adequate functioning of serotonin transporter? What do you think is required for adequate functioning of serotonin transporter? 1, serotonin only. 2, serotonin and sodium is required. 3, you require serotonin and histamine, or what do you think is the answer for this question? Sodium, calcium, potassium, or just serotonin is enough? A lot of them are choosing sodium, and the next best answer, a lot of them are choosing calcium. So let's try to see what possibly is the correct answer. For us to see the correct answer, I think you need to understand when you're talking about serotonin transporter, right? I've drawn a T here for us to understand serotonin transporter because I want to make 3 points here. If you look at serotonin transporter, the electrolyte which plays a role in better serotonin transporter reuptake is sodium. You require sodium sitting on the serotonin transporter for it to function and reuptake the serotonin. So you require sodium, not necessarily calcium. So sodium is the most important one. That's the answer for this question, along with the serotonin. Of course, without serotonin, nothing will work, right? But it is also important here with the T, you can also see this side. I've written allosteric modulator site. Why this is important is because this allosteric modulator site is the site where a lot of our drugs go and sit and fine tune the modulation. It makes the transporter release or reuptake much more. So modulation happens from the modulator side. So that is why I've graphically made it like serotonin transporter looks like a T, one to remember the sodium, another to remember the serotonin, and the other one to remember the allosteric modulator site. That's something which can help you to kind of understand serotonin transmission in a much, much better way. Okay. Now, one of the transporters which I did not touch upon is the glutamate transporter. You remember the slide where I spoke about SLC6 and SLC1? You remember, right? In SLC1, I'll just show you for a second, because if you have forgotten that, it might be helpful for us to know here. Yeah. SLC1 is linked with glutamate, right? So when you're talking about these glutamate transporters, you need to understand glutamate transporters are 1 to 5, and they are little different because they work on the SLC1 gene family rather than the SLC6 family. And instead of they working on the sodium and chloride, they basically work on potassium counter transport. The SLC6 gene family members are all dimers mostly, whereas this is a trimer, 3 units. 3 units. This is a trimer, whereas that is a dimer. That's another important difference which happens with glutamate transporter. So if you can kind of understand these things, it makes a lot of difference when you're reading about these drugs in future and trying to understand it in a better sense. There is this chemical which plays a role as a neurotransmitter, where enzymatic action is much more important than reuptake inhibitor. Of course, we know acetylcholine does play a role, but one of the important enzymatic action activity which brings about ending of this neurotransmitter is histamine. So histamine, more than having reuptake, right, the enzymatic action seems to play a role in this. Why is it important for us to know is because these chemicals which are released in the brain, its effect lasts for few minutes to few seconds, depends on different areas and how fast the reuptake happens, right? So it's important for us to know how these neurotransmitters effect might go away after some time. And that's how reuptake pumps as well as these enzymatic actions play a role. Which enzyme degrades which neurotransmitter. These are all some basic biochemistry aspects which you can read up and learn for us to understand. Moving ahead, an important point which I would like to highlight here is this. So let me ask this question. When an agonist or antagonist has not bound to a receptor, see, there is a receptor in a person and there is no agonist sitting there, there's no antagonist sitting there. So what do you think will be happening in that receptor junction? Will there be zero activity or there will be some activity? What do you think is the answer? 1 or 2? Poll, please, Sriram. Zero activity or some activity. What do you think is the answer? There is no agonist sitting there. There is no antagonist sitting there. So what do you think is the answer? Majority of them have put across as some activity. 20% of them have chosen to put it as 21% of them have chosen to put it as zero activity. Whereas majority, I say some activity is there. This some activity which is there is what we call as some baseline activity, or it is also called as constitutive activity or baseline activity. That's important for us to know, because this constitutive activity can vary in different people based on the receptor density which is there. Okay, if the receptor density is very high in a place, the constitutive activity could be much more. If the receptor density is lesser in that area, the constitutive activity could be much less. It is like if you have 1 watt, 1 bulb, the light will be little bright. If you have 1 watt, 10 bulbs there, it will be almost like 10 watts, right? So depending on the number of receptors sitting around there, the constitutive activity will matter. Now, clinically, would it make sense for us to understand it? It is important for us to understand because a lot of times when we see our clients, right, they come to us with a crisis. Does it mean they were absolutely fine earlier? No. When we listen to their history, we know they have been impulsive. We will know that they have been anger issues. They have been temperamentally anxious. But recently, in the last 3-6 months, they might be having an illness or a disorder diagnosed. So it is kind of an understanding that it's almost like a baseline activity. And now newer additional problems which are happening. So our first target is to intervene with therapy or medications to see whether the disorder components can be reduced. if possible, can we make a difference in the constitutive activities what we're looking at? So clinically, that is what we do. So in the same way, in psychopharmacological aspects, when you're talking about receptors and all, it's good to know there is something called as constitutive activity. Why should you know this? Is because of one important situation, which is the situation where you should know about this constitutive activity. Any idea? It is a situation where you should know about something called as inverse agonist, right? Uh, Agonist increases the level of activity to its full potential. Full agonist increases let's imagine um, the baseline activity is at 40%. Okay, 40% is the baseline activity. If I give a full agonist, it will push it to 100%. If I give a partial agonist, it will push it to 60, 70, 80%, that level. If I give an antagonist, it will not push to zero, it will bring it down to 40 and leave it there. That baseline constitutive activity will still remain. So for you to remove the constitutive activity or the baseline activity, you need to give an inverse agonist. So inverse agonist might push it down to minus 20 to 20%, 15%, 5%, or it will try to push up to 0%. Did you understand? So an antagonist might only bring it down to the baseline, but not push it below the baseline. For it to be pushed below the baseline, you require an inverse agonist. So that's why you should know the concept of constitutive activity. So read upon it for it to understand much better about these things. So we will be talking about many drugs, which will be agonists, partial agonists. We'll be touching upon these concepts further and further for us to take it up. Now let's move ahead because there's a lack of time. I kind of have to cover a lot of important areas. So let me ask you this important question here. I did mention to you about ion channels and those things, right? Like, which is one of the other transduction systems. So when you're talking about ion channel, there are two important ion channels we should have. One is the ligand gated ion channel. Another one is the voltage gated ion channel. Simple. Ligand gated ion channel and voltage gated ion channel. Ligand gated ion channel obviously are nothing but basically ionotropic receptors, and these are ion channel linked receptors. These are ion channel linked receptors. So these are called as ionotropic receptors. And please remember, ion channels basically work much faster. So a lot of your quicker effects are not because of G proteins. G proteins take a lot of time to work, whereas ion channels work much quicker. Simple example is if you give buspirone is a 5-HT1A partial agonist. 5-HT1A partial agonist. So it works on the G protein receptor. So it takes some time to work. It cannot have emergency effect. What can have emergency effect? In emergency rooms, we have lorazepam, diazepam, all those benzodiazepines, right? They work basically on ion channel. So a drug which works on ion channel works much, much faster. A drug which works on G proteins works much more slower. So that's important for us to understand. A ligand gated ion channel basically is a pentameric structure. It's a pentameric structure, which is basically a 4 transmembrane protein kind of a region. A ligand gated channel is something like that. It is easy to remember again. See, for example, ligand is how many alphabets? 6 alphabets, right? So 6, 5, 4. Ligand gated channel is a pentameric, basically kind of a channel, and it has 4 transmembrane proteins in it. It has 4 transmembrane proteins in it. So there are 5 subunits, and the ion channel will be sitting in the middle, and there are pentameric units. How many units are that? There are totally 5 units, and each of the unit will have what? Each of the unit will have about 4 transmembrane proteins. That's the simplest way to understand ligand gated ion channel. Easy to remember. LIGAND is 6 alphabets. So basically there are 5 subunits, there are 4 transmembrane proteins, and ion channel. See, what I'm trying to do here is whatever we learn, I want all of us to remember that, because the more we remember, it just makes us enjoy the subject much, much better. Otherwise, these look very dry and kind of crazy looking subject. So our job is to make it easier for us to learn. So that's the aim of the whole process. So some of the important ligand gated channels are the GABA A receptors, nicotinic cholinergic receptors, the serotonin receptors, the only important ligand gated one is 5-HT3. That's the only one which is a serotonin receptor, which is ligand gated. All the rest of the serotonin receptors are what? They are G protein coupled receptors. Got the point? That's something which you should not forget. All others are G protein. This is the only one which is ligand gated kind of one. Glycine receptors are again examples of ligand gated channel. Now, with this understanding, we can talk about each of these receptors, but I think we'll keep it for the future sessions where we will be talking about all of these things little later. Now, since I mentioned to you about G protein, let me highlight to you an important aspect of G protein which you need to know. Yeah. G protein is basically a 7 transmembrane kind of a protein, right? So basically there are 7 transmembrane protein. That is why it's called a serpentine receptor, serpentine receptors. Okay. It almost like goes like a snake and serpentine receptors. Now, G protein coupled receptor, GPCR is the common term which is used, right? G protein coupled receptor, GPCR. So GPC, 1, 2, 3 alphabets. So please remember there are 3 basic units which are there in a G protein coupled receptor: alpha unit, beta unit, gamma unit. And what is the most important component in it? It is the alpha unit, which is the most important in it, because that is what has GTPase activity. That is what has the GTPase activity, which plays a role further and further. And please remember, the G protein coupled receptors work on second messenger system. And how does it bring about second messenger system? Easy to remember. C, alphabet C, you can remember. Second messenger system works on the cyclic AMP and its pathway. It works on calcium. It works on the cyclic GMP. The calcium one is linked with the phospholipase. The full term is phospholipase C pathway, which is linked to the IP3 and the DAG. So we'll talk about these when you're talking about individual drugs, how these pathways work. So it's good to know the second messenger system is linked with this C proteins. Is linked with cyclic AMP, calcium, and cyclic GMP. C, and C, for us to remember some of the important second messenger system. So I'm kind of highlighting these things in a very simple way so that we kind of understand it much better. Which is the crucial subunit which I mentioned for this G protein coupled one. The crucial subunit which I mentioned is the alpha subunit. Based on the different types of alpha subunit, you can have different names for it. The alpha S is the stimulatory one, which increases the cyclic AMP. Alpha Q works basically on the calcium receptors, which basically works in the calcium second messenger system. Alpha T works on the transducin and leading to the phosphodiesterase enzyme activity, leading to decrease in cyclic GMP, The stimulatory one increases the cyclic GMP, whereas this decreases GMP. The alpha inhibitory also plays a role, but it plays a role again in decreasing the cyclic GMP. So these are different methods by which alpha unit is sitting will decide different kind of G proteins which are playing a role. So these are some important aspects which we need to have in mind when we are talking about different kind of neurotransmitters. Now, before we kind of wind up for the day, in the next 10-15 minutes, I'll try to highlight how different areas of the brain can play a different role. It's good for us to know that. Now, if you take communication, right, the communication in the brain system can be completely intracellular communication, intercellular communication, and communication can reach to the localized area, the particular area in and around that area, communication can happen, or communication can be to the other zones or other parts of the brain. So that's how different zones can happen. And that's how communications can go and get complex, right? This is where it leads to different kinds of important circuits which come in. We'll be touching upon some of those circuits when we are talking about different conditions. Let me highlight a few important points here. One of the important things is you need to understand is we would have read about something called as Pepys circuit, right? Pepys circuit is one of the oldest circuits which has been spoken about playing a role in emotions, it was called as emotion circuit and those, but actually speaking, you need to understand Pepys circuit has no role in emotions, and it has no amygdala in it. So PAPE circuit has no role in emotions. A lot of research now says PAPE circuit is mostly linked with visuospatial memory and episodic memory and those kind of aspects, much lesser in emotions. I mean, indirectly it can be linked to emotions, but lesser effect on emotions, even though it was called as circuit of emotions, PAPE circuit. Now, PAPE circuit is basically a circuit which starts from the hippocampus and goes around and comes back to the hippocampus. Starts from the hippocampus, comes back to the hippocampus. That's PAPE circuit. The important components being MATCH, the mammillary body, the anterior thalamic nuclei, the cingulate gyrus, and the hippocampus. That's how we need to kind of remember and remember these circuits. I've tried to keep a very simple aspect here. Now you need to understand the other way of looking at circuits is by kind of looking at something called as frontostriatopallido-thalamic circuit. Frontostriatopallido-thalamic circuit. So as the name suggests, frontostriatopallido-thalamic circuit. So that's how it goes deeper and deeper, right? So frontostriatopallido-thalamic circuit. There are 5 important frontostriatopallido-thalamic circuits which we can look at. 2 of them play a role in motor system. 3 of them play a role in the non-motor system. Now, what are the motor systems we are talking about? One is the skeletal-motor system. Another one is the oculomotor system. That's 2 of them which play a role. Whereas when you're talking about the non-motor system, we're basically talking about DLPFC, that is the dorsolateral prefrontal cortex. We also are talking about the lateral orbital frontal cortex, and the next one, which is we are calling as the medial orbitofrontal cortex. So the non-motor systems play a role in aspects like attention, concentration, emotional regulation, behavioral changes, and those. Whereas the motor aspects is basically talking about skeletal-motor activity and oculomotor activity. So circuits can be kind of divided in these simple ways for us to understand and learn. One of the important areas which we obviously have to know is basal ganglia, right? Now, basal ganglia is and related circuits is something we'll be talking upon in few lectures, especially when you're talking about antipsychotics. We'll be touching upon some of these aspects again. You need to know when you're talking about basal ganglia, easy to remember BASAL, 5 nuclei are important. The caudate and the lentiform nucleus. The lentiform nucleus is nothing but putamen and globus pallidus put together, right? This globus pallidus has internal component and an external component. What else makes the basal ganglia? You need to understand the caudate nucleus and putamen together make the neostriatum, whereas the globus pallidus is what is called as the paleostriatum or the older stratum component. Okay, so these are all important aspects which we should know. The paleostratum is the globus pallidus, whereas the caudate nucleus and putamen together become the neostratum for us to remember. Which are the other 2 nuclei which you need to add in the basal ganglia system? The substantia nigra and subthalamic nuclei. Since we are talking about psychopharmacological aspects here, let me highlight an important point. If you look at this whole aspect, you need to know basal ganglia, basically the one which are marked in the darker system, right? The corpus striatum, that is the caudate, lentiform nuclei, that is the putamen and the globus, they all basically secrete GABA. They all basically secrete GABA, whereas substantia nigra basically secretes dopamine. What does subthalamic nuclei secrete? Basically glutamate. So this is why you know how motor system facilitation and other things happen in the whole brain functioning. Now you need to understand, I started the whole lecture trying to talk to you about various neurotransmitters and giving an highlight on how neurotransmission basically happens, how exocytosis happens, how the coupling happens, how the receptors function, the ion channel, the G protein. Now I'm talking in a broader sense of various circuits. So what am I trying to do here is I'm trying to lay the foundation for us to kind of understand things in the future lectures on psychopharmacology. We'll be talking about how this whole cocktail comes in action in our patients and how we can intervene and make a difference. So before we wind up for the day, I thought I'll highlight, there are a lot of things which we could have spoken, but I want to highlight this and then kind of wind up for the day. So it's important for us to understand, if you're thinking and if you're doing something, basically some brain activity is happening, right? So you need to understand, these days, a lot of research is happening and a lot of neuroscience is happening, trying to talk about two important circuits. Two important circuits. What are the two important circuits they're talking about? One is the task negative network. Another one is the task positive network. One is the task negative network. Another one is the task positive network. This task negative network is also called as default mode network. Today, a lot of research papers on meditation, mindfulness, yoga, all of this starts talking about default mode network. If you don't understand what default mode network is, the other name for it is something like a task negative network, uh, which is nothing but, if you're talking about default mode network, basically it involves some specific areas of the brain like the medial prefrontal cortex, which is one of the important areas involved in default mode network, the posterior cingulate cortex, the precuneus, and the inferior parietal cortex. Now, what does this default mode network do? Basically, have you not seen patients with depression coming and complaining one thing? Sir, I cannot stop worrying. I cannot stop thinking about it. It keeps on running in my head. Rumination, daydreaming, by default, thinking and thinking and thinking, aimlessly thinking, all those things which are very exhausting to depressive patients is all function of default mode network. So default mode network is supposed to be hyperactive in patients with depression, is what you need to understand. In patients with depression, the default mode network could be hyperactive. In fact, if you actually work with a lot of your patients, you'll see a lot of patients will have rumination as one of the important problems which we need to address. We need to help them with a lot of distraction strategies. We need to teach them some therapeutic strategies to work on their system. Otherwise, it's very, very difficult for them to get out. Just putting them medications might not help. So this default mode network could be so strong in them that it is difficult to break with just medications. Now, what is this task positive network? It's kind of opposite, right? In default mode network, you're daydreaming, you're not doing much, you're just lost aimlessly. Whereas in task positive network, for example, the last few, last 1.5 hours, I've been concentrating on what I'm delivering, right? So it is task positive network. Constantly, I'm in full focus and trying to concentrate and trying to say the best possible information in the short duration. So my task positive network has been very actively working during this time. The DLPFC, it's already asking when should I tell how much time is left. So it's constantly running through in my head all these aspects. Anterior cingulate gyrus is the other important component of the task positive network. The insular cortex is another important one, and somatosensory cortex. So these are all important areas of the brain which plays a role in task positive network. If you see today, mindfulness, cognitive behavior therapy is being spoken as left, right, and center treatment for almost every psychiatric condition we have, right? In fact, for well-being, they use this. Why? Why? Because this task positive network is tapped in it. When you consciously do this focus and attention and concentration, you are getting away from the default mode and getting into this task positive network. That is why these are extremely effective, is what you need to understand. So the time is about 2 minutes left for 9, where we need to wind up, I understand. So before we kind of stop here, I think I might have run through a lot of things for you to jog and think about. And maybe I think you would have realized you have learned a lot, or you might have kind of understood a few aspects pretty clearly. But you need to understand, in terms of enormity of the brain's ability and functioning and complexity, what we actually have discussed is too small a point for us to understand. There's so much more for us to learn. I think I've kind of given you some structure on which you'll realize how we'll be taking up further and discussing this, being a very, very huge topic to be discussed in 1.5 hours. I've tried to keep it very quick and fast. Maybe in the next few discussions, we'll be taking up a lot more interesting discussions, and we'll also see how we'll kind of put it into practical application. Thanks for listening, and you can always reach out to me on the link we have shared. You can send your feedbacks, you can ask questions. If I am able to answer, I'll answer. Otherwise, I'll figure out the answer and definitely get back to you. Thanks for the opportunity, and looking forward to catch up with you all the next Friday. Thank you.
Thank you, Dr. Mohan. Actually, I wouldn't know how the last 1.5 hours actually went. I've been reading up the feedback of whatever the attendees have put in, and I think it's a great motivation for me to get this sort of feedback from this sort of first session itself. I'm sure a lot more people will be interested to watch this session also. For the benefit of the viewers, it's going to be there on the YouTube and on the website. And people who have missed will definitely get in the sort of link to get this sort of lecture going again. The most innovative way was you put in a lot of questions, kept it more interactive. They kept getting involved in the form of responses. I think all these innovations will really keep the interest of the audience going. The feedback is great, excellent. Thank you, Mohan, for making a wonderful beginning today for us. I also have a resident in my hospital who actually took up psychiatry after listening to you as an undergraduate, and he was so delighted to meet you for the first time when he met you in Kansas, is what he was saying. So I think you've been a really wonderful motivational speaker in so many ways. Keep it going, and all the best for the further sessions, Dr. Mohan.
Thank you. Thanks.
Thank you, Sriram,
nice
for anchoring and wonderful technical coordination. There's no glitches at all. Thank you, Sriram.
Thank you, sir.
Thank you,
Thanks,
all the
Sriram. Thank you very
attendees
much.
and the postgraduates and colleagues who have attended. And if not for you, these programs cannot be held, and there's no success to programs at all. Thank you for attending. Good night and have a nice evening. Good night.
Thanks.